evening, everyone. So I'm going to start this evening, jump straight into it and talk to you about the ageing process. So beginning at around the age of 60, our immune system undergoes some dramatic changes that aren't just our hair dropping out or going grey, but also we have some age-related changes happening which continuously progress to a state of what's called immunosenescence. The ageing immune system loses its ability to protect against infections, cancers, and fails to support appropriate wound healing. The body becomes less able to respond to infections, and it's unable to develop long-term immune memory anymore. So immunosenescence plays a key role in the development of respiratory diseases that are more common in older people, such as asthma, COPD, and respiratory infections. Structural changes also occur in the lungs and in the chest wall, and as a consequence of the ageing process, which gradually lead to a decline in measures of lung function and mechanical barriers at the mucosal surfaces. These structural changes include muscles, ribs, and spine, causing a decrease in the size of our thoracic cavity, which impacts normal lung function, and hence we get more respiratory issues. So ageing has been shown to affect both the inspiratory and expiratory respiratory muscle strength, which is associated with poor cough strength and the ability to clear particles from our lungs. These physiological changes are involved in exacerbating respiratory infections and poor outcomes in our elderly. So during this phase of our life, vaccine responses are also typically impaired. And as we know, the main objective of vaccination is the prevention of infection by specific pathogens. So as you can see from this graphic on this page, a healthy immune system is able to effectively create an antibody response after having an antigen injected. In the ageing body, it produces a diminished antibody response and a diminished T cell immunity. Okay, so vaccination has many degrees of impact. We prevent illness. We can look at the eradication of smallpox as just one. And whilst no vaccination is 100% effective, the effect of an illness is lessened due to our body already having antibodies stored in memory to fight off illness. Herd immunity is having a vaccination to protect those around us who are unable to be vaccinated. The direct impact of vaccination on the maintenance of homeostasis is achieved through the prevention of infection-induced complications. Other positive effects include enhancing the trained innate immune response by reprogramming those innate cells in the body to respond more efficiently to threats from other pathogens and slowing that immunosenescence by altering the epigenetic clock and harnessing the pool of memory B and T cells to enhance responses to new infections. Immune fitness or immune training involves establishing lifestyle habits that can improve our immune capacity. So we now know that having good eating habits, good social relationships, not smoking, limiting our alcohol consumption, exercising, controlling stress levels, and establishing a correct vaccination program can have a really positive impact on the quality of our immune response. So vaccines can positively contribute to the immune fitness in ways and mechanisms that are only now just beginning to be understood. So therefore, a life course vaccination is fundamentally a great tool for achieving healthy living. So I'll quickly move on to the consent. So consent is something that we all need to be doing in our everyday practice. We always need to have valid consent to perform any task when dealing with another person. So for consent to be considered valid, it needs to meet the following criteria. It needs to be voluntary. The decision to either consent or to not consent to the proposed treatment must be made by the patient themselves and must not be unduly influenced by health professionals, friends, or family. It needs to be informed. So the patient must receive sufficient information about the proposed treatment to enable them to make informed consent. It needs to be current. So consent must be reviewed if, after a consent was obtained, the patient's circumstances, including treatment options and risks, have changed. and it needs to cover the treatment to be performed. So the treatment provided must fall within the scope of consent that has been given by the patient. It should also be given by a patient who has capacity. So to understand the information presented to them and to make that decision, remembering that capacity may be diminished by illness, age, medication, drugs and alcohol, amongst other things. So if you're working in an aged care facility, consent may have to be given by someone who is not the patient. So consent on behalf of an adult lacking capacity. So you need to carefully assess your adult's capacity to give valid consent to a vaccination. And if that adult lacks that capacity, you need to refer to the relevant state and territory laws for obtaining consent from a substitute decision maker. For example, flu vaccine for an elderly person with dementia. You need to look at your guardianship laws and see if that client has an enduring power of guardianship. So documenting your consent is also extremely important. It's expected practice to have informed consent documented in writing by way of either a signed consent form or notes in the healthcare record for all healthcare interventions other than the most minor of healthcare. Okay, valid consent usually lasts for around 12 months, although this is a generalisation and there can be justification to extend that consent, but also to shorten the consent. So being vigilant with the changes in your residents, especially around their cognition and ability to consent for their own health issues and procedures, is extremely important. As part of the routine admission paperwork, we advise that you should have a consent document regarding all vaccines for that age group available for family, residents, and or the next of kin. Ensure you include relevant documentation, brochures on each of the vaccine preventable diseases to assist families with that valid consent. A yearly review of your consent paperwork should be conducted to ensure that if and when clinics such as a flu clinic is arranged, you'll know immediately which residents or which families you'll need to approach. Ask your reception staff to have the consent forms on hand in the reception area with the appropriate brochures so that when relatives visit, that quick check-in conversation can be had. Quite often, the first port of call person, which is the receptionist, knows families and relatives well, and handing over the paperwork and relevant brochures and then alerting clinical staff can assist with streamlining your consent process. Regular contact with families through posters, brochures, newsletters and information sessions advocating for vaccinations to protect their loved ones is always helpful. Reminding them that it is the diseases that we're protecting them from rather than simply a new vaccination can also help. Those residents that are undergoing guardianship with the public trustee will need a new consent form every 12 months. Having the standard consent form available to send to them and a routine check of the consent paperwork will ensure that these residents are not left out. Let's talk about some vaccine preventable diseases. So top of our agenda would be the influenza or the flu vaccine. Sorry, influenza. It's a viral infection causing fever and chills, sneezing, coughing and a sore throat. Older people over the age of 65 are at higher risk of needing additional care if they contract influenza. Complications can include pneumonia, breathing problems and death. The best way to prevent influenza is to have a flu vax every year. So pneumococcal. Pneumococcal disease is a bacterial infection caused by Streptococcus pneumoniae. The bacteria are easily spread through coughing, sneezing, saliva and mucus, and the symptoms can range from mild to severe depending on where the infection is in the body. Complications can include pleural effusion, meningitis and even sepsis. Zoster or shingles. So shingles is a viral infection that causes painful blistering rash. It's caused by the reactivation of the same virus that causes chickenpox. And so while symptoms typically last 2 to 3 weeks, shingles can become serious. It can lead to nerve pain that can last for months called post-herpetic neuralgia or other serious complications including pneumonia, hearing problems, blindness and swelling of the brain. About 1 in 3 people will get shingles in their lifetime. COVID-19, the be-all and end-all illness. So COVID is a disease caused by severe acute respiratory syndrome, coronavirus 2. COVID-19 can affect anyone, but it's more serious for older people, pregnant females, and people with underlying medical conditions. Most people with COVID-19 will only get mild symptoms now, but some people can become very unwell. Continuing to wear a face mask, practicing good hygiene, and maintaining physical distance from others is still the bee's nuts for keeping people protected against COVID-19. Vaccination rates are currently in aged care facilities are currently around 55-56%. COVID is still affecting our community and hundreds are still dying from COVID-19, especially our at-risk vulnerable elderly people in aged care facilities. Pertussis, commonly known as whooping cough. It's a respiratory tract infection which is highly contagious, starts as a cold and progresses to long bouts of coughing. And the coughing can go up to 100 days. It used to be called the 100-day cough. Can lead to complications such as pneumonia, seizures, and encephalopathy. And finally, we've got respiratory syncytial disease. It's a common virus affecting the upper and lower respiratory systems. It's highly contagious. It can be mild and present as a common cold. It can be serious in some, requiring hospitalisation. Risk to health is greater as we age or if we have an underlying medical condition. And our First Nations people have a higher risk of serious illness. So the vaccinations that cover these vaccine preventable diseases. The WA schedule is on this slide here. It was last updated on the 1st of October. It's blue and red at the moment. It's usually updated about every 6 months. This particular one I have actually pulled apart, and this is only the section that actually is for adults. So you've got your adolescent and adult section and the seasonal flu section. So these are actually pages 2 and 3. The childhood section is on the front page. We also are lucky enough in WA to have a specific Aboriginal immunisation schedule. It was created earlier this year by the Department of Health, and it's helpful if you have clients who are Aboriginal to ensure that they're receiving the correct doses of the correct vaccinations at the correct time due to the differences in our schedule. So if you do have some Aboriginal people in your facility, by all means, download a copy, an updated copy of this, and you'll be good to go. So the current schedule. I have included MMR in this slide because whether or not we like it, people born after 1965 are going to turn 60 very soon. So MMR is the current recommendation for it. The measles, mumps, rubella is actually 2 doses. The first MMR combination vaccine was introduced in 1969 and the second dose of MMR was recommended in 1992. In 2003, adults born after 1965 were recommended to have a second dose of MMR to give them that 99% coverage. It's thought that people born prior to 1966 will have natural immunity, and there's a very high chance that they had the disease in childhood. Currently, the MMR is funded for adults born after 1965 by our state government. And prior serology doesn't need to be completed. So if someone comes to you and presents and says they would like to have one, they can have one. It's especially recommended for people that are travelling overseas or becoming pregnant. Our second one is the influenza. So the flu vaccine is recommended yearly and it's free for those over the age of 65 on the National Immunisation Program. It was also free during May and June of this year in WA. Annual vaccination is the most important way to prevent influenza and its complications. It can be safely co-administered with other vaccinations. And pneumococcal disease vaccination. Infants and elderly people have the highest burden of pneumococcal disease. Pneumococcal disease is disproportionately affecting our Aboriginal and Torres Strait Islander children and adults as well. The optimal pneumococcal vaccination program for Australia is currently under review and the immunisation handbook chapter has just been updated. So at present we have Prevnar 13 and Pneumovax 23 as the funded vaccines under the program. The Australian Immunisation Handbook has an interim recommendation for the use of the extended valency vaccines, which is Vacnuvance and Prevnar 20. And while they're not currently funded in the NIP program, they have been approved by the Therapeutic Goods Administration to be given to certain people. Shingrix, or our Zoster, replaced Zostavax as our Zoster vaccine on the National Immunisation Schedule back in November 2023. As I said earlier, about 1 in 3 people will get shingles in their lifetime. It's a 2-dose schedule, with each dose being between 2 and 6 months apart. This vaccination is more reactogenic than the previous Zostavax, and the more common side effects include pain at the injection site, redness, swelling, tiredness, muscle aches, headaches, fever, and gastrointestinal symptoms, and these disappear generally in the first few days. And finally, COVID-19. So our current ATAGI guidelines are recommending that adults over the age of 18 consider having a dose every 12 months, especially if they're travelling. For those over 65, it's recommended that they have a booster every 12 months. And for people over 75, they should be having a booster every 6 months, as well as severely immunocompromised people should be considering having a dose every 6 months. So a couple of extra vaccines that aren't included on our schedule, but I would like to talk about. One would be the pertussis vaccine. So unfortunately, it's not included in the current NIP schedule, even though the complications from contracting pertussis can be devastating. So please also consider that residents will often be visited by people who are not protected, so protecting them becomes even more important. The pertussis vaccine is not standalone and can only be given with tetanus and diphtheria. So every 10 years for a tetanus vaccine, every 10 years for a pertussis vaccine. It can be co-administered with other vaccinations and should be considered. Also, then we have the RSV vaccine, which is called Arexvy. We're all aware RSV is around and it causes the upper and lower respiratory tract infections. It can be quite severe in our older people and also in our very young. This year, the state government committed to immunising our young vulnerable babies to Nirsevimab, which is a monoclonal antibody, and this program proved to be quite successful. Over 22,000 babies were immunised, and the initial data through is basically suggesting that there's been a significant decrease in hospitalisation rates for RSV this year, which is great. Next year, there'll be a rollout for pregnant mothers and babies. And on the other end of the scale, the TGA has also approved Arexvy and Abrysvo immunisation for the older adult. A single dose of RSV vaccine is recommended to protect older people. The RSV vaccine may be given at any time of the year, but where possible, it should be offered at the start of the RSV season. We're hoping that this will be included in the National Immunisation Program next year. However, it does look unlikely. But that's pretty much all I wanted to talk to you about as far as our vaccinations go. Thanks for listening, and I hope you've got a bit more knowledge about what vaccines your residents need. A final point to remember would also be that as a worker in an aged care facility, it's always important to consider what you would do to prevent illness as well, what you can do to prevent illness yourself. So ensuring that all staff are up to date with vaccinations will help lead to that herd immunity that I spoke about earlier. So now I wanted to welcome and hand over to Charmaine, who's going to get us all up to speed with the GP ACI. Thanks, Charmaine. Over to you.
Thank you very much, Jodie. And thank you for the opportunity to present on the General Practice Aged Care Incentive Program. The General Practice Incentive Program, the benefits and the aim are very similar. The benefits for the residents within a residential aged care home is the same as the aim of the aged care incentive. It wants to provide a more holistic, coordinated care, a chosen primary care provider, which in the case, if we talk about the incentive, we will refer to a responsible provider and a care team. A comprehensive medical assessment, a medical examination that includes a history and a diagnosis is included in the benefits. There will be more regular visits, which will be incorporated within the incentive and will be a mandatory requirement before the incentive is actually paid to the general practitioner and the practice. Annual care planning, preventative strategies, as mentioned by Jodie already, we can see the advantages of having a strengthened and formalized relationship between a resident and a primary caregiver that can provide immunizations, influenza, pneumonia, where it can then reduce the risk of preventable or avoidable hospitalizations. It can address the health concerns as they arise. It also looks into a very comprehensive follow-up from a GP within a residential aged care home. So the requirements are quite straightforward. Care planning services must be provided over a period of 12 months. So they will be looking the incentive pays in quarters, but the requirements must be met over a 12-month period. So 2 eligible care planning services must be delivered by the responsible provider. Eligible care planning and services can include the comprehensive medical assessment, the contribution to or review of multidisciplinary care plans, a residential medication management review, and coordinating or participating in a multidisciplinary case conference. With the quarterly visits, there needs to be 2 eligible regular services per quarter, each in a separate calendar month. At least one of the regular visits must be provided face-to-face by the responsible provider. A second face-to-face visit may be provided by the responsible provider or alternative provider. The alternative provider in this case can be another member of the patient's care team who acts in the direction of the under the direction of the responsible provider. In MMM areas 4 to 7, practices will be able to provide up to 4 regular visits per 12-month period over telehealth items where they are unable to provide face-to-face services. Quality patient service person-centered care. This is really important, and what the aim of this general practice incentive is, again, with the access to safe, effective and quality clinical care, which means that there will be consumer engagement, dignity and respect. When the patient is having, or the resident is having their medical assessment, it will be in accordance with their needs, their values, their goals and their preferences. It will optimize health and well-being with shared decision-making with family and carers. The assessment and care planning will be coordinated, collaborative and holistic. There will be advanced care planning included, and with case conferences and medication management reviews, it will be ensure the quality of patient care. Clinical governance and quality improvement. If you just listen about what the clinical assessment for the patient will include, you will see that it will promote a culture of safety and quality. You can drive and monitor improvements. You can include strategic and operational goals to recognize and acknowledge the need for a fundamental reform of the aged care process to enhance the well-being of your residents. You can even acknowledge that My Medicare is a new voluntary patient registration model. You can include it in your clinical governance group. If you have a formal or informal agreed partnership with the general practice or the general practitioner that will be delivering a service within your residential aged care home, you will have a mix of skills. You have experience and knowledge that will actually build onto even an advisory group, problem solving, suggesting improvements. One member of your clinical governance group, you will showcase that they have experience in the provision of clinical care. As with the strategic plans and with guidelines from the Royal Commission and with audits, you will be taking all responsible steps to comply with the guidelines. You can include staff training and education about the incentive. You can include even education for your family and carers of the resident within the facility. And within your strategic and operational plans, you can showcase that you have a shared care in collaboration with your general practice and the clinician with clear roles, with responsibility and accountability.